It's a real pleasure to introduce Professor Tabia Akintobi. She's a professor of community health and preventive medicine and Associate Dean of Community Engagement at Morehouse School of Medicine in Atlanta, Georgia. She is a social behavioral scientist with a master's and doctoral degree in public health from the University of Miami and University of South Florida, respectively. As principal investigator of the Centers for Disease Control and Prevention-funded Prevention Research Center, she demonstrates leadership in local, national, and global community-based participatory approaches and research, addressing health disparities and advancing health equity. She leads or collaborates in way too many to cite, and I don't know how she does it, projects addressed on this model of community-driven research. She's also principal investigator for Georgia's Community Engagement Alliance Against COVID-19 Disparities, designed to understand factors that contribute to the disproportionate burden of COVID-19 in Black and Latino communities. Her research interests include maternal child health, mental behavioral health, cardiovascular health, and diabetes prevention. And she's guided by her training in public health, social epidemiology, social marketing, community-based participatory research and evaluation. Topics, I should note, that at least when I went to medical school, we were taught very little about. And it shows. So when I read several of her papers, and this one in particular, I knew we had to invite her to Keynote for this conference. This is a paper that was published in August 2020. She wrote, "Racial ethnic minorities have historically borne a disproportionate burden of illness, hospitalization, and death during public health emergencies, including the 2009 H1N1 influenza pandemic and the Zika virus epidemic. This disproportionate burden is due to a higher level of social vulnerability. Individual and community characteristics, note that, individual and community characteristics that affect capacities to anticipate, confront, repair, and recover from the effects of a disaster among racial ethnic minority populations than among non-Hispanic white populations." That is exactly the topic that we are here to address today. So I am doubly thankful for Professor Akintobi's scholarly contributions, but today, even more personally grateful that she has gone to the trouble of flying from Atlanta to join us today. I really do appreciate it, and thank you very much.
Thank you, Dr. Cohen, and thank you, Dr. Daly, as I get my mask off to make sure to remind us all that we need to be safe to be able to do the important work of advancing precision medicine. This is a wonderful opportunity, and I feel like, just based on what I've heard, I'm with those who are like-minded, but I hope that in the few minutes that I have, I will inspire you and hopefully challenge you to think out of the box when we consider advancing health equity through precision medicine and realizing the vision of precision medicine, which is to make sure that we customize healthcare through medical decisions, treatment practices, and products that are tailored to subgroups, not based on their genetics, but based on a context that should be understood and chronically engaged towards improving population health. So I want to start by giving you a taste of the important community and patient groups that are central to advancing precision medicine. I'll talk a little bit about our work and what's more important, the so what and now what. What are the implications of what I share and the experiences that I've helped to lead or support to advancing precision medicine, particularly when we think about race, ethnicity, and the importance of community patient-centeredness. So if you could cue the video, thank you.
My role as chair of the Community Coalition Board really is to ensure that in every aspect of the work, community residents are participating with academia to ensure that these projects are just not research projects, that are projects that really help to enable neighborhood residents to move forward, but also kind of provide the knowledge and the data back into the neighborhood so that it's owned by the community.
Weight loss equal health gain is a mini-core grant that we received through the Community Coalition Board at Morehouse School of Medicine. And it is about the community getting well. It's about nutrition, health, losing weight, doing what we need to do within the community to pass on not just to this generation, but to generations to come, about better eating, about being more physical. Morehouse made it possible, so we have our own areas in our own community, which will meet the needs of our participants here.
My organization, Redemption and Advancement, was awarded the mini grant from Morehouse School of Medicine because we focus in on violence prevention and men's overall health. We're looking at serving 25 to 35 men who have been impacted with incarceration, being able to reach out to these individuals, help them to understand what it means to live a healthier, productive life, not only through making better decisions, but also with making healthier decisions for themselves with the way they eat, drugs and alcohol. There's studies that directly link doing these things in a better way to making better decisions and being able to change lives.
The south side of Atlanta is really being neglected because we have more vacant houses, we have high-class graffiti, things that are just not conducive to good living. We have had people to come in to help us with HIV, diabetes, and things like that. That's how we are impacting our community.
What we're clear about is that people have to be well and healthy in order to be those individuals that move to better jobs and employment that helps us to create better communities. Neighborhood residents can really look to this institution being a community partner and saying that they helped us to deal with issues that we face on a daily basis that allowed us to improve our quality of life.
Thank you so much. So I frame my discussion on research, race, and ethnicity with attention to the bigger picture, right? So I'm hoping that those of you who are in the room, and particularly those who are with us virtually, you represent a couple of audiences that I understood would be listening, contributing, and learning with us today. There may be some of you that are clinicians, some of you who are researchers. Hopefully there's some policy folks as well as community or patient leaders. And we know that there are at least 3 stakeholder types that must be engaged, ideally from the beginning, to help us to understand the complexities of race, but also to understand how we should be conducting research and precision medicine initiatives that matter. And when I talk about what matters, I mean that we want to have statistically significant and impactful research, but we must ensure the value proposition for community and patient groups also from the beginning. It involves any type of relationship that is sustained towards a common goal. So I remember when I was in grad school, and one of the first courses that I took, and some of you may reflect on your own, it was on social exchange theory, and it probably has been one of the most relevant theories that I've applied both personally and professionally. So you can think about your own personal life or professional life when I describe what social exchange theory represents at the end of the day. People stay, organizations stay in relationship because they are getting something out of the exchange that they value. Again, sustained relationships, which are based on bonding, relationships, and understanding, are because each party is getting something out of the relationship that not only demonstrates that they are understood, but that there is value added in that relationship. And so when we consider the opportunity, as was described by Dr. Daly, to better understand and engage racial and ethnic groups in the value and promise of precision medicine, we must think about their intentional engagement, not just to provide advice or to give us their perspectives, but to expand our notions of team science such that patient and community representatives are a part of, are co-creators and translators of what race and ethnicity means, and how to engage those that are either on the fence or who are justifiably resistant and opposed to engagement with groups that historically have represented imbalances in power, medical atrocities that we cannot ignore, and really may be the barriers to engaging in effective precision medicine initiatives. So the work that I speak about and that which you saw through this example comes from the Prevention Research Center's program that's funded by the Centers for Disease Control and Prevention. And through that, we do a lot to engage actively communities in initiatives designed to address health disparities, and most recently to partner with the National Human Genome Research Institute to talk about issues of community engagement in advancing precision medicine. So as a bit of history and to kind of frame your own thinking, our Prevention Research Center with forefathers and mothers who helped us to really think about race more broadly back in the early 90s. The theme of our Prevention Research Center, which rolls really nicely off of my tongue now, is risk reduction and early detection among African American and other minority communities, and we consider this a coalition for prevention research. Over 20 years ago, those that were thinking about the opportunity to advance population health through our center knew that we had to think thoughtfully about other minority communities. And so if I was in class with you all, I would ask you all to think about what other minority communities mean. We know that they are not groups that are solely defined by race and ethnicity, but they may be subgroups that are defined by multi-layers of identity that we must understand, appreciate, and engage to do our work in engaging racial and ethnic groups more effectively. So I'll speak for myself as one example, and you can think about your own experience and identity. I am a Black female, a proud daughter of immigrant parents from Jamaica, who was steeped in an expectation that there were no ceilings for what I could attain. Now, when I walked out of my house, I was met with the realities of living in a community that was very different from the community that I saw just as far as the door of this auditorium. And it is that experience that really lit the fire in my belly about the importance of figuring out what was the difference in experience between me as someone with great promise, but as I was talking to someone right before this talk, whose US Census identity reflected a risk for risks. So that's a bit of my story, but hopefully it helps to shape your understanding that race and ethnicity cannot alone be our understanding of the experiences and the whys when people think about their experience of the healthcare system, their experiences of health, their experiences of us in the academy, and while many of us have dedicated our lives and our careers to righting the wrongs with respect to health disparities, we represent that which is not to be trusted, and therefore there is justified hesitancy that we must right. So with that framing, I'll talk a little bit about this Community Coalition Board. And certainly for those of you who are interested, I'm happy to share how this model, which we've published and has been applied to many research studies and precision medicine initiatives, how you might consider this, what I call flipping of the script towards not just understanding what race and ethnicity is, but applying a model towards community leadership and not advice in advancing precision medicine. So first, this group as it is applied, and I'll talk about some of the ways that it has been adapted, it is designed to be a community governance infrastructure. It is very much by design because the members of this group clearly identify that there were inequities of power, control, and leadership between the academy and community and patient groups. And so for those reasons, our bylaws, which have been ratified over time, require that as a clinician, as a researcher, and a principal investigator, I cannot hold a leadership seat. When we are applying for grants or considering initiatives, if there are not enough community leaders at that meeting, we cannot vote. So in the early years, there were times when I had a great NIH grant that I was proposing that had great, what I thought, health equity implications, but because there were not enough community residents to vote on it, I could not submit the grant. So all of these bylaws and infrastructures were designed to ensure that when we talked about engaging racial and ethnic minority groups, that it was not just by having a token one or two in the room, but it required leadership in number, voting power, and authority by groups that had been historically tokenized at the table to check off boxes that were designed, quite frankly, to solely ensure that there was adequate recruitment and retention of participants. If your mindset is that you have a study that is designed to effectively engage racial and ethnic minorities in research, it is time for an expansion of your perspectives. Disenfranchised groups, if they have seen anything through the pandemic, they are very aware of the counterfeit. And just as my family, interestingly, they finally know what I do. I can't prescribe medication. But thanks to the pandemic, they said, okay, that's what public health and health equity is about. They're learning what disparities mean. And so we are at an important a point in time where we can effectively get it right, or be ineffectively met by communities, particularly racial and ethnic minority groups, who now understand that there are differences, not just in what they bring to the table by way of their identity, but ways that the academy and clinicians can further marginalize and exploit them. And I don't think that's any of our intention. But this type of infrastructure has been used to advance and adapt and address important initiatives, particularly those most recently related to COVID-19. So some of you who are clinicians, community residents, or researchers have a local Clinical and Translational Science Alliance Award, and through this governance structure, we have scaled and adapted it for the state of Georgia to advance what we know is not only the science, but also the art of effective community-led clinical and translational research. And so what that means is that we must attend to the peer-reviewed literature and what has been esteemed effective or best practice. But it also means that what we know about racial and ethnic groups through the literature must be tempered and balanced with today's experience, right? And so through the CTSA, we've evolved the approach, and I would suggest and challenge you to consider 3 disease-agnostic groups that should be a part of your cloud of thought leaders and knowledge holders as we think about race, ethnicity, and establishing the vision and advancing the art of precision medicine. One, and first and foremost, are community and patient groups. They must be at the leadership table in numbers that reflect what we want, and that's to flip the script toward their leadership and power. So community and patient groups. The second that are important are those that actually can do something about it. So consider social service agencies, health departments, and even policy leaders that should be responding to what they hear from racial and ethnic groups, whether they be patient or community-based, and that can actually take action in ways that often in the academy we're bound by red tape and are a little slower. And then third, and in the spirit of humility, should be clinicians and researchers. We are the ones that can help to define what success looks like, can support evaluation of initiatives to ensure that they have impact. But these 3 disease-agnostic groups can be applied to any research or clinical intervention if the minds around the table are similar in terms of their intent to advance health equity. Through this model and through the adaptations that I'll share with you, we've been able to not just establish, but to continue to sustain our trustworthiness. Some of you who are familiar with the AAMC's recent initiative designed to not talk just about trust, but trustworthiness is the pursuit to unroot racism, to establish a position of anti-racism, and more importantly, to marry our research pursuits with the intent to flip the script and advance equity in power between those that have historically been left out and should be in the positions of not just engagement, but leadership in team science. So other ways that we've done this are through the Diabetes Center for Translational Research. Some of you have been involved in this P30 funding mechanism where, again, we have scaled our approaches to ensure that patient and community groups are leading and not advising our work. And most recently, through RADx Up, we are looking at approaches to advance ways to engage those who are at risk for or who have diabetes, and to ensure that they understand the importance of COVID testing urgently. And then, as was shared recently, we are leading and are a part of a national national movement funded by the NIH called SEAL, the Community Engaged Alliance Against COVID Disparities. And through this, we seek to advance community-centered, community-created, disseminated, and translated information through effective communication strategies, COVID-19 confidence and trust, and then vaccine uptake. So this is one case in point, but whatever your research or clinical intention, you can plug and play in here what your mission or goals of the research are, but I challenge you to take a bit of what you've heard from me and certainly reaching out to me to find out the ways that we've done it, to consider the path towards being effective in your precision medicine or other research initiatives. Much of your efforts should be focused on communication and engagement, establishing and maintaining trust. And through confidence in research and established trust, these are the paths toward engagement and uptake and confidence in research. I would dare say that about 75% of your efforts should be focused on communication, building confidence and trust. Those are the pillars and the pathways towards uptake, confidence, and participation in the research. And certainly they must be community-centered, co-created, disseminated, and translated. So the ways that we communicate certainly have had to be outside of the box. I was not trained to be an effective marketing communications expert. Some of the folks that have been the moderators for these events related to research trust, much less COVID understanding and vaccine confidence have included influencers and thought leaders that are probably nothing like us, right? Whether they were media personalities, those in the hip hop or music industry, whoever it takes to be that influencer is the important draw towards having a safe space to talk about how they feel about research, their mistrust, much less COVID-19. And so where we chronically must also be is understanding people's why. If you look at the literature for African Americans and other minorities, you might guess that it is things like Tuskegee, Henrietta Lacks, the Nuremberg trials, among many other atrocities related to medical and research mistrust that were the reasons. But the truth is that while for some groups, depending on their age, and experience, that might be the reason for their reluctance to participate in precision medicine and other research initiatives, but some were more current and were things that when we knew about them, we could quickly dispel myths, identify the right influencer towards their engagement. Participation, trust, and leadership are our paths towards effective precision medicine. But those things cannot happen without a current appreciation for the why. So thinking a bit more broadly, when we think about those that represent racial and ethnic groups that are disproportionately impacted by poorer health outcomes when compared to their white counterparts. I always like to include this quote, just for us all to consider. Thomas Jefferson said this without attention necessarily to research or public health or what we now call health equity or health disparities. The reality is that while our Creator may have created us equal, even from the womb, there are inequities that are based on what people come with, and then what they experience after that, that results in inequities that cannot be denied. And it should be our intention to acknowledge what is and to make sure that our research and our clinical and community leaders help us to advance the path forward. And so race and ethnicity is not enough. This is just one example of the reality of a disproportionate experience of poverty that is held by those that are in racial and ethnic minority groups, whether they are African American or Latino or Latinx, among others. And they speak to the cycle of poverty that is based in income inequality that has been a reality in our United States for over 400 years. The cycle that it creates related to poorer opportunities for education that result in less likelihood of high school completion, the opportunities to get an education and to be successful, communities within which the opportunity and exposure to people who look like them that represent hope and opportunity, poverty hurts. It is not race and ethnicity that hurts, but the implications of that are what hurt. This is just one example of the connection between race and ethnicity, socioeconomic status, and educational opportunity, particularly for African American and other minority communities, that we must understand and unpack, and make sure that we have an eye towards resilience. So my partner in good, Dr. Herman Taylor, who you'll hear from later on, have really dedicated our careers and some partnered work to understand resilience. What is it about individuals for whose demographic profiles may by the literature demonstrate that they should not be successful, but they are? We must learn about the other side of the coin and make sure that we as clinicians and researchers are educated on what that experience is like and how those types of thought leaders can help us to make sure our methodology is attuned to what success, not just in life, but in research can look like. So we hear about health disparities, and I don't take for granted that everyone here understands what that means. So we know about health disparities, but health disparity populations today, because certainly the definition changes, includes these groups that are disproportionately impacted in different ways, sometimes independent of each other. So it may be about race, it may be about socioeconomic disadvantage, it may be about geography. So we know that there are real differences in terms of people's access to health care and opportunity in rural versus urban settings. And it may be about sexual and gender minority status, as well as immigrant status, as well as disability status. And what we're very clear on is that one person or one subgroup can represent many of those identities. So when we consider race, when we consider the term health disparities, we must understand that there are multi-layers of identity that we must understand and consider in our leadership structures to make sure that we actually take advantage of this moment, which we hope is a movement toward doing precision medicine better. And so intersectionality, I think, is rooted in what I'm saying. I described my identity. I probably didn't know until I got into my Masters of Public Health program that we were of lower socioeconomic status. There was so much that I knew represented a culture of giving and certainly being our brother's keeper that made me feel like I didn't miss anything. But on paper, we were of lower socioeconomic status. But I challenge you to consider the concept and notion of intersectionality. Simply put, intersectionality is the concept that all oppression is linked. More explicitly, now in the Oxford Dictionary, there is a definition of intersectionality as the interconnected nature of social categorization, such as race, which can be layered or independent of class, and gender, and they're regarded as creating overlapping and interdependent systems of discrimination, disadvantage, and I dare expand it to experiences of health, experiences of the healthcare system. And a part of that is because most of us as researchers or clinicians just have not been trained, right, to be able to know how to understand and present to individuals who represent many layers of identity in the ways that would best serve or encourage their participation in research. Some of you may have seen some version of this equality versus equity slide or schematic, and I would challenge us that hopefully, if it's the first time that you're seeing it, you would consider an equity perspective to your research, and that is that there are different things that people come with, and those are the boxes that you see people standing on. And they also represent different heights that speak to that intersectionality or that experience. Our work is to figure out what research, what precision medicine approaches should be that are tailored towards their experience. And we can't get to that without engaging them as active leaders and helping us to understand their experience as a racial or ethnic minority, but also those various other layers of identity that require our understanding and their leadership. A few moments ago, Dr. Culhane actually spoke from an article that was actually re-released through CDC in a special edition focusing on advancing health equity, eliminating health disparities, and improving population health. He already stole one of my quotes that I no longer have to read, but a part of the understanding on the whys behind the disproportionate impact and experience of health disparities among racial and ethnic groups requires our understanding of historical context. And many people who are not trusting of research and precision medicine, they may not necessarily understand all of the history. And we have the opportunity to be able to explain to them when they come to me and say, this is just because I'm Latinx or just because I am African American or Black. And no, it's not just because. So racial and ethnic disparities have always existed in the United States, and differential health outcomes between African Americans, other minorities, and non-Hispanic white Americans have been part of the American landscape for more than 400 years. Many measures of health status have been used to assess differences among groups. More recently, health researchers have advanced concepts and constructs of health equity and social determinants of health, much of the discussion that you saw framing our talk and conference today. There's also a policy landscape. We are very clear that obesity, asthma, depression, diabetes, heart disease, cancer, HIV, and many other disorders that put vulnerable populations at greater risk of dying of COVID-19 can be linked to a policy determinant. One of my other partners in good, Dr. Daniel Dawes, penned a book called The Political Determinants of Health. People's experience of environments that create barriers or facilitators to the experience and the opportunity of quality or optimal health care are steeped in the policy or political determinants of health. It's those policies that create the experience that we now call the social determinants of health. Those things must be unpacked and understood from the perspective of the lived experience. And again, I will say that we must not only engage effectively, but we must position these thought leaders through the lived experience as members of our team, expanding the perspective and the notion of team science. So something else that it so happens, Dr. Culhane, that Dr. Taylor and I have been working on for a few years is through Morehouse School of Medicine, a scholarship and ideal when we think about research. And that is what has been patented through Morehouse School of Medicine to be called TX. We recently penned a paper on it in ethnicity and disease, and it is an expansion and an elevation representing 5 equally important and relevant tenets of research that represent our history at Morehouse School of Medicine, but also an institutional investment of money to support this type of research. It involves engagement of community and patient groups, ideally from the inception of the research concept, particularly racial and ethnic minority groups. It involves collaboration among researchers across the translational continuum. So that means that social behavioral scientists should be intentionally seeking to engage basic scientists in collaborations that advance translation of that work to and with communities. Interdisciplinary teams must include folks in industry, right? Those who are can be the path towards advancing action surrounding how the research can be uptaken in communities of practice. In all of this, there must be results that demonstrate evidence, and the results must be adopted or adapted in communities of practice. So the tenets of TX scholarship, our investment in prioritizing it as an institution, the acknowledgement of it through NIH as an innovation in an approach to research that doesn't prioritize any one tenet but requires all of it, and certainly requires through racial and minority community groups that results are adapted or adopted in communities, really holds us to be accountable to ensure that we're not just doing research for research's sake, but there must be something in it through results that demonstrate impact, that change a system where they live, work, play, and lead. This is an example of it. It's probably harder to see on your screen. It means that research can happen on any part of this ring, and the rings are interconnected. It can happen, the research can emanate and come from a community initiative. It can and should involve a policy implications or change, and must include certainly basic science through which innovations in what can work with communities and patient groups are founded and emanate. It is not unidirectional and must involve different players with community and patient groups at the helm of our understanding, better methodology, and better results. So yes, we've published this. Yes, we've garnered lots of funding for it, and have engaged and been thought leaders in writing about it. Most recently through the Morehouse model that's published through Johns Hopkins University Press, there are details surrounding how people can actually do this work in ways that are rigorous and reflect community thought leadership at the helm. But for the purposes of closing us out and hopefully inspiring you, I will close my comments with a few recommendations that are inspired by someone who you saw in the video. She's since passed away, but her important, very simple question inspires me daily. And that is, the research is good. And if there was a particular day when I was presenting a research idea that frustrated her, she'd say, you know, Tabia, that's cute. But exactly what are you going to do with the research after you get it? If we are thinking about ways that we can be more precise in the engagement of racial and ethnic groups, we must invest in chronically being able to answer that question. And ideally, for the research to be good, it requires our attention and established relationship, trustworthiness with marginalized group that we must reposition to seats of power to educate us on what works and what their why is. So a few things for us to consider and for us to think about, to frame this day and hopefully what happens after it, is that we should assume and embrace that race, ethnicity is complicated. It is not based on what people present with, but an experience that provides an opportunity for us to take this moment and create a movement towards doing research and community and patient-centered work more effectively. We must challenge our notions of team science. For us, we already might feel uncomfortable in collaborating with researchers who are not in our department. That's already a stretch for some of us. But what could our precision medicine initiatives do if we blew the walls off of our concepts of team science and engaged patient and community leaders as a part of our team science models? LaShawn, who you saw speak in that video, has acquired grants where I was the consultant because they were the thought leaders that should be advancing the initiative. So how do we continue to flip that script of doctor or clinician knowing best so that we establish the trustworthiness that demonstrates that we are not in control, but seek to understand towards collectively advancing population health? Make room for essential precision medicine co-creators and translators. We already need their leadership to translate research into what communities see are effective and what we do with it that matters to them. And we must invest resources and time to foster and sustain trustworthiness. It has meant me thoughtfully looking at my budget and my timelines when I'm submitting grants to say that we are going to invest in community thought leaders, not just by having them included through letters of support, but by hiring them, not in one or two in terms of number, to ensure that our street credibility and our credibility among racial and ethnic minority groups is reflected on our team. And then finally, the concepts of diversity, equity, and inclusion. What are our motives? What are the optics? And what is the reality? DEI has become extremely popular over the past year and a half because of our pandemics related to COVID, related to social injustice, among many other things. We should not be looking to only seek to diversify and have equitable inclusion of researchers who look and are diverse, but we must ensure that our approaches strive to ensure diversity, equity, and inclusion in terms of racial and ethnic groups, representing the communities and patients that should advise, inform, and steer our efforts towards being more effective to understand and do this work better. So I will stop here. I'm pleased to continue the conversation and look forward to a great afternoon of learning and hopefully getting some steam for our continued efforts to advance precision medicine. Thank you.